Wonderful. I think we will get going because we're tight on time. So good evening, everyone. My name is Sarah Jane Ryan. I'm one of the co-chairs of the Southeast Coast region of the CSP. So thank you so much for joining us this evening. The Southeast Coast are on their third webinar now. We have had previously a general one just on applying for jobs and one that is focused on an MSK case scenario. And this evening, we're really lucky to be joined by three very experienced cardiorespiratory clinicians from Medway NHS Foundation Trust talking about the acutely unwell respiratory patient. Our first slide there, for any of you who joined us previously, is the same as it was before. So how we're going to manage this, just because of the sheer volume of you on the call, is that if you have any specific questions, if you can pop them in the Q&A at the top bar of your Teams. And when we're kind of doing the interactive bits, which is when the guys will ask you kind of questions around the case that we're focusing on, if you can use the chat function for your answers for that. So if you have any specific questions, and that can be broader than the case that we're looking at tonight, put in the Q&A and one of us will answer you in there, or we'll put it to our colleagues, our cardio-rest colleagues. And if you're interacting with any of the questions that they've posed, you're putting it in the chat. As I've mentioned, this will be recorded and we'll pop it on our website afterwards in the next few days. You can have a look, and do please have a look at the other sessions as well. So just to do a very brief introduction, I am very pleased to welcome Natalie, Tom and Lorna, who will be presenting this evening. These three are hugely experienced cardiorespiratory physiotherapists working in Medway NHS Foundation Trust in Kent, and are not only very experienced physios, but also brilliant educators and have been supporting students for many years. So this session, I hope you'll get loads from. So without further ado, I am going to pop over to Natalie to start us off.
Hi there, everyone. We're just hoping that from looking at a particular scenario of an acutely unwell medical patient, that will just give you a little bit of insight as to the type of answers we'd expect in an interview situation. And hopefully you'll gain a little bit of insight into an acutely unwell medical patient. So first of all, we've got a typical scenario for you. It's a 78-year-old man by the name of Mr. Smith. He's presenting to hospital following a fall, and he sustained some undisplaced rib fractures on the right-hand side, and you know that he's got a background of COPD, so chronic obstructive pulmonary disease. So we just want you to have a little think about, if you've got this type of patient that's coming to hospital, what sort of problems do you think this patient would potentially be experiencing? So just want you to have a little think. And just on the question and answer, if you just want to keep it simple, but just think about some typical problems that you might expect from this patient.
Natalie, can you see the chat? You're getting loads of answers.
Oh, I am obviously not on the right bit.
So not on the Q&A, on the chat one. Yeah.
Lovely. Let's just have a look. Okay. Yeah, brilliant. So some of you guys have said about pain. That's actually the biggest problem that this person is going to be experiencing, especially with fractured ribs. And consequently, if they're in lots of pain, yeah, he may well be feeling a little bit breathless. Anxiety, definitely. So someone that's come into hospital following a fall, they're in an unfamiliar environment, things are out of their control, they're in pain, struggling to breathe. Yes, they're going to have an element of anxiety. Yep. So I can see poor basal ventilation there. So if someone's in a lot of pain, they're going to potentially not be able to take deep breaths, but they're potentially going to be shallow breathing, and they might be using their accessory muscles to help with their ventilation. And we know he's already got a background of COPD, so he's already got an underlying lung condition, and this is on top of that. So yeah, absolutely. So someone said reduced expansion on the right side. Yeah, so if the fractures are on the right side, he might be potentially guarding on that side. His posture might be affected because he might be trying to protect that right side. So yeah, absolutely reduced expansion on the right-hand side. Just give you a couple more minutes just to see if anyone has any other problems. Someone said reduced confidence with mobility post-fall. Absolutely. I think you're all kind of coming up with similar problems to this patient. Brilliant. So before you've even spoken to this patient, before you've even gone to them to carry out an assessment, you're already starting to think about hypothetical problems that this patient might be experiencing. You're happy to go to the next slide then. So yeah, so we concur with what you said. So he's going to be in pain. Fractured ribs are incredibly painful. Often they're conservatively managed, and analgesia is like the biggest management plan that you're going to have for this patient. But yeah, if they're in pain, they're not going to be breathing deeply, which can potentially cause atelectasis. They may potentially need supplemental oxygen whilst they're acutely unwell. As we said, he's had a fall, he's in an unfamiliar environment, so he may well be feeling anxious and have a loss of confidence. And sort of related to all of that, he might not be as mobile as beforehand. And if he's not coughing effectively, that may well mean that he's at risk of retained secretions. So coming on to the next slide there. So if you think about, you've already got your potential problem list, and this is not exclusive. There's different ways you can think about assessing this patient, but just want you to consider what things might you be thinking about in their subjective assessment and what things might you be thinking about in their objective assessment that you want to look at. So again, if you can just pop your answers in the Q&A or the chat even. So someone said about ensuring animal.
Natalie, you've just muted yourself.
Sorry. So yeah,
Thank you.
analgesia is absolutely crucial, because without adequate pain relief, you're not going to manage to do much else. So yeah, so when you're looking at the fall, we want to know mechanism of injury. Did they trip over? Did he lose consciousness? Did he feel dizzy? So absolutely you want to explore the reasons for the fall in your subjective history, because that will help formulate again your problem list and your treatment plan. Yeah, so someone said about the fact he had his background COPD. So how well managed was this COPD? For example, you might be thinking about his previous medications that he was on. Was he on oxygen? What was his exercise tolerance beforehand? Yeah, absolutely. Someone's looked sort of at his social history. So thinking about his baseline function and what the home environment's like, that will come into play when you're starting to think about the discharge plan for this patient. Auscultation and cough strength, yeah, that'll take up part of your objective assessment. Some great answers here, guys. Yeah, chest expansion. You want to see how deeply they can breathe, and also is it symmetrical on both sides? And consideration of the MDT. Yeah, good. Just give you a couple more moments just to think about your subjective and objective history. that it from you guys? So yeah. Yeah, someone said about quad strength. Important also if he's had a fall. Lovely. So if we come on to the patient assessment then. So again, before you do anything with the patient, you want to consider your infection control. So making sure that you've cleaned your hands and you're wearing the appropriate PPE. You're trying to build a rapport with the patient. So obviously introducing yourself, explaining why you've come to see this patient, what the purpose of the review is, what do they like to be called, and you want to think about their privacy and dignity. So think about, have you pulled the curtains around? Are they dressed appropriately? You don't really want to be thinking about listening to their chest and having the curtains wide open so that everyone else in the bay can also see them. And it's important to get informed consent. So once you've explained why you're seeing them, the purpose of your visit, making sure they've got an understanding of why you're seeing them, making sure they give you consent for therapy input. And if, for example, they're not able to consent, just clearly documenting why they can't give consent. And if you're still seeing them because you think it's in their best interest, just making sure you document your reasons for this. So when you're thinking about the environment, so again, before you've even spoken to the patient, you're taking a lot of clues about how well this patient is just from looking at the environment around the patient. Are they on oxygen therapy? Are they attached to any monitors? Have they got ECGs attached? Has this person got a catheter? Is there any things on the table that might indicate how poorly or how well this patient is? We know this patient is a COPD patient. Has he got any smoking paraphernalia on the table? Has he got his usual inhalers on the table? Is there a sputum pot? If there's a sputum pot, what's in the sputum pot? How much phlegm? What colour is the phlegm? Things like that. So you can get information before you even actually approach the patient. It's sort of taken on board to then again help formulate the treatment plan. So moving on to the next slide. So the first bit is your subjective assessment. So obviously, this is the medical model that we're going through, looking at, first of all, their history of present condition, and then going all the way through to work out what their baseline function is. And it's a chance for the patient to describe in their own words what their symptoms are. And if you try and give them open-ended questions, that gives them the freedom to actually give you the symptoms from their point of view. But if you've got someone that is particularly short of breath or working quite hard, you might want to start open-ended, but then you might want to change to more close-ended questions so they're not becoming really breathless trying to answer all your questions. It can be quite a lot of questions you're asking, so you might want to kind of do more close-ended questions as you're progressing. So thinking about all the things you said about, have they got any pain? Have they got any phlegm? Have they got any breathlessness? And getting those subjective symptoms from their point of view. Past medical history, we know that he's got a background to COPD, but are there any other long-term conditions that you want to be aware of? There's a massive link that if you've had a COPD exacerbation, that their cardiovascular risk goes up. So you want to consider all those other comorbidities as well. Have they had any surgery? Is there any surgical history? And also, if this person has got COPD, are they on any things like long-term oxygen therapy, ambulatory oxygen? What's their normal exercise tolerance? Again, you're trying to establish the baseline so you know if things are different to normal for them. Thinking about the drug history, so with the inhalers, for example, is he compliant with the inhalers? You will start thinking about technique and things like that as you go on to the management plan, but yet you want to know, is he compliant? Is he getting any side effects of these medications? Are there any known drug allergies? From a respiratory point of view, you might want to know if they have nebulizers at home, and also they should be having their annual vaccines for common respiratory pathogens. So you're thinking about flu, RSV, COVID and pneumonia vaccines for patients that are at risk. The social history, again, you're sort of trying to ascertain their prior level of function so that you can be a bit more realistic in your discharge planning. If you've got someone that is normally housebound, normally very limited with their mobility, you're not going to be expecting this person to run a marathon next week. So you just need to be realistic as to what their previous function was. You can think about occupation. So if this person's had any previous environmental exposures, by that I mean any chemical dust exposures related to their job that might make them more at risk of lung conditions. You want to ask about the smoking history, thinking about not just how many cigarettes they've smoked, but for how long. Obviously, we know that 1 pack year is 20 cigarettes a day for a year. And if you have more than 20 pack years, that can increase your risk of respiratory conditions. If they are an active smoker and you've got someone in a hospital environment that suddenly can't smoke and they've smoked all their lives, you might be starting to think about smoking cessation advice. Do they need any nicotine replacement therapy whilst they're in hospital? Things like that. So you want to know smoking history, and not just smoking, including vaping history as well, because often the vapes contain nicotine, so they may still be craving that nicotine hit. So you need to just ask a little bit more about their vaping history. And as I've already said about their home situation, you're trying to establish, especially if this person's had a fall, have they, are they in a house, in a bungalow, a flat? Do they normally manage stairs? What mobility aids do they use? Have they got any equipment in situ already? What is their usual exercise tolerance, and what is limiting their exercise tolerance? Is it normally breathlessness? Is it pain? Is it weakness? Again, so you can start formulating a accurate problem list for that patient. In terms of pets, that's more kind of relevant if you've got someone, for example, with asthma. Do they have a history of atopy? Does pet dander make their symptoms worse? So that's more for your asthmatic patients. This patient's coming with a fall, so we want to know, has this person fallen before? Have they got a pattern to their falls? Have they had any community involvement in fall? Are they known to fall services? Do they get things like their eyes checked? Have they got suitable footwear? With their home environment, is it cluttered? Have they got any loose fitting rugs? So again, trying to work out things that then can determine what you need to consider in your management plan. And ultimately, we want to rule out any red flags. So any seriously underlying pathologies or conditions that need immediately being dealt with. So things like chest pain, drenching night sweats, they're coughing up or vomiting blood, all of those sorts of questions you need to be aware of, because that's something you need to rule out before you go on to your normal treatment plan. So going on to we in this trust use the whole systems approach because obviously everything in your body is interconnected. So if you were to just purely focus on respiratory system, you may well miss that someone's not opened their bowels for 7 days, which again can have an impact indirectly on your respiratory system. So by looking at every single system, you can make sure that you're logical, ruling out any potential contraindications or precautions to your treatment plan. You can also assess your response to treatment depending on what your initial objective assessment is. And so this is kind of our logical format to go through to make sure we don't miss anything out. So hopefully you've all heard of the News 2 score. This is literally just a national early warning score, which includes things like your respiratory rate, SATs, oxygen delivery system, blood pressure, heart rate, temperature. And essentially it's a track or trigger system so that you can pick up if someone is deteriorating. Often people will show signs that they're deteriorating before it comes crashing down. So you use this track or trigger system to see how unwell this patient is or if they're deteriorating. So going through for this patient, we've just done a couple of examples of what you might find in an objective assessment. So here's CNS. You can look at AVPU. We don't tend to look at the GCS score. That's a bit more complicated with AVPU. is a nice quick way to check the CNS. So his patient is alert and orientated. Looking at the cardiovascular system, actually this patient is fairly stable. He's a little bit tachycardic, but that's not unexpected with this sort of scenario. Respiratory system, this patient's on oxygen. He's got SATs of 89%, and actually you need to be mindful of what his target saturations are. So oxygen should be titrated according to someone's target SATs. And if someone has got COPD and they're maybe at risk of CO2 retention, they're probably on scale 2. So actually 89% is not necessarily alarming in this scenario. Obviously, like you guys said, you're checking respiratory rate. You want to be checking for the full minute, not counting for 15 seconds and times it by 4, because this person might have an irregular breathing pattern. So counting for the full minute. And sometimes if you say to someone, I'm going to count them for the full minute, they completely change their breathing pattern. So you can sometimes pretend you're checking the pulse and then count the respiratory rate whilst you're pretending to check the pulse. Listening to the chest. So we'd expect potentially that this patient is sounding quite quiet all the way through if they're taking shallow breaths because of the pain. And if potentially they are retaining the secretions, you may well hear some crackles as well. We've already said that this person might be guarding on that right side because of the fractures. So if you check their expansion, you've got the hands on either side of the chest and you're checking to see if it's nice and symmetrical, you'd expect it to be expanding about 2 to 4 centimetres to see whether there's any unilateral problems. We've said about considering the ABGs. Again, that's just checking to see whether they're a known CO2 retainer or not. Renal function, is he managing to pass urine? In this circumstance, he is. There's no problems there, and he is eating and drinking as normal. Hematology, for this patient, again, he's got raised inflammatory markers, so we're suspecting an infection of some sort because his CRP and his white cell counts are raised to normal. But you also want to make sure you're ruling out any problems with his electrolytes, so thinking about his sodium and potassium. If there's problems with the electrolytes, that might impact how much you can push him in terms of mobilizing. Musculoskeletal, obviously we know he's got his rib fractures. Are there any other problems? Any problems with the shoulder? Someone said about quad strength. You want to make sure you check all 4 limbs. Has he got full functional range of movement, which he has? But we can see that he's not really coughing effectively, which might be why he's not managing to cough and clear his phlegm. And obviously you want to make sure you check blood sugars as well to make sure that's not going to be a precaution for his treatment. The other thing that's not on there is his skin integrity. So, you know, if he's fallen, how long did he fall for? Did he suffer a long lie? Potentially you might have pressure areas. And again, if you're starting to get someone out in chairs, you might need to consider, does this person need any pressure relieving equipment? Next slide. So you've done your subjective assessment, you've done your objective assessment. You guys already thought about the potential problems for this list, for this patient. Is there anything new from that objective assessment that you've just had that you might consider as a problem for this patient? Or are you happy that your problem list is probably similar to what you were already thinking from when he presented to hospital? If you are happy that you think it's similar, we'll just go on to the problems. So you've assessed them all. And this is what you formulated as your physio problem list. So, yeah, he's got pain due to rib fractures. You can quantify that by exactly where is the site of the pain, and you can ask him the visual analog scale just to give you an idea of severity of the pain, both at rest and when he's moving. So normally the visual analog scale will go from 0 to 10, 0 being there's no pain at all and 10 is the worst pain you can imagine. He's obviously on a little bit of supplemental oxygen, so we know he's got an oxygen demand. He's got a weak cough, probably related to the pain that he's in. So he, because of that, is at risk of retained secretions. We've already said about because of the pain, he's attached to oxygen, he's anxious that he might not be mobilising. And we know that potentially he's anxious because of that recent fall. So you formulated your problem list. And obviously what you want to think about is how you're going to manage those problems in turn, either medical management or physio treatment plan. So if you think about those problems in turn and just think about what types of treatment, either medical or physio, would you be thinking you might want to carry out for this patient? So if you just pop it in the chat, what sort of treatments do you think you'd consider for this patient? Yes, so supported cough. So
Natalie, you've muted yourself again. Still muted.
muted and then
There you are. You're back.
is it done?
Yeah.
I'm so sorry, it sort of must be a delay. So yeah, supported cough, rolled up towel or a pillow you can use to give the supported cough. Yeah, active cycle of breathing techniques. So you can focus on either the deep breathing part of the active cycle of breathing to try and improve lung volumes, or you can focus on the huffing side of things to try and help with sputum clearance. Positioning and mobility, absolutely. So we want to get this person up and mobilizing. Inhaler review, yeah. So we want to make sure we've optimized him from a COPD point of view, checking that he's got correct inhaler technique. If he's on a dry powder inhaler device that needs someone to be able to breathe in strong and deep, he might not be able to do that if he's in a lot of pain and only able to take shallow breaths. So they might want to consider nebulizers in the short term. Anything else you might think of to do to help with lung volumes? So get referral to community teams, that would definitely be part of your discharge plan. We hope that obviously if you've medically optimized this patient, that their symptoms will improve. And as their symptoms improve, you should be able to wean the oxygen off. And you do that obviously titrating the oxygen according to their target SATs. So centre spirometry, absolutely. We'll talk about that in a second. So yeah, so great answers. So absolutely, we're thinking about techniques to manage lung volume, techniques to clear phlegm. Pain management is absolutely key to enable you to do those things. So I'll hand over to Lorna so she can talk a little bit more about the specific physiotherapy treatment plan.
Hello everyone, thanks Nat for your initial part there. So as Nat said, we're going to move on now to the physiotherapy treatment plan. So we've just created a structured one that obviously in the interview you were asked about the treatment plan for this sort of patient. These are the sort of things that we'd be hoping to hear from you. So again, in the chat, you've really touched on everything that we think is really vital for this patient. So pain management is such an important part of the management. It's really going to help you treat anything that you then go on to find on during your assessment. So sort of planning your time to go and see them, speaking to the nursing staff, the MDT, making sure that that pain relief administered prior to you going to them, and sort of acknowledging that as well when you get there, so that they know that you're aware just of how uncomfortable they feel. Next one we've got there is appropriate oxygen delivery systems, and we are going to move on later to just talk briefly about some different oxygen types that this patient might be needing, and that's really vital, because actually your oxygen delivery system can also help with your treatment as well. So if they're needing a certain level of oxygen, it might be that it needs to be humidified. If it's humidified, it's going to be less drying, which means that any secretions that they are struggling to clear are going to be much easier to clear. And of course, we're thinking about the target saturations for that as well, to make sure that we're maintaining, you know, an accurate level of saturations to ensure that they are stable. And then we're going to move down to the sort of 3 main, or potentially 4 main areas that as a physiotherapist you're going to be looking at when you're treating somebody with a rib fracture. So first of all, it's your ACBT, and that is your foundation. It works in every aspect of your treatment. So regardless of the condition, regardless of what they come in with, that ACBT foundation of treatment is going to build on everything else that you bring to treat that patient. So the cycle of deep breathing, following with the huff, and then also the cough. Now, Nat touched on having that supportive cough and also having that for the huff as well, but using the cycle of breathing to make sure that you're using the huff first within that cycle, and then moving on to a big cough at the end when you feel you've gone through the process well enough to start moving the secretions to the upper airway. It's really important. Then the next one is the incentive spirometer, which I think somebody had written in the chat as well, which again, very important with rib fractures or any sort of lung volume issue. Somebody that is sort of able to follow instructions and able to follow their own drive of treatment as well. It's really positive treatment option for that. It's going to encourage lung volumes. We would always encourage them to be in upright position, either in the chair if possible. Nat touched on the other bits and pieces that you might need to consider before moving somebody to the chair, but ultimately our case looks relatively stable, and therefore we really encourage mobility alongside one of these other adjuncts. And we would say to be using it sort of 2 to 3 times every hour, every other hour, just to make sure that they are really working on that lung volume. It will help to stop the small parts of the lung from collapsing and causing atelectasis. So it just prevents that risk. And if it has already started to have those effects because of the reduced sort of expansion, then we can start to use that early on and hopefully prevent it from getting worse. And then the next one, I'm not sure if this one was mentioned in the chat, but we were talking about using a PEP device, which is a positive pressure. It creates positive pressure within the lungs, and it just helps to stop those airways collapsing. So really beneficial to use with any patients that have got lung volume concerns, and especially those with your rib fractures. And again, it just prevents that collapsing of those airways, and it helps to move those secretions up further into the larger airways, which see beside that adjunct will help to clear those secretions out. And hopefully it will be a little bit easier because they'll be using that process, and the supportive cough, putting it all together creates a good treatment plan for those patients. So then we did touch again on that early mobilisation. So it's vital with any patients that come through and into the hospital, if there isn't a reason for them not to be mobilising, we should be mobilising those patients. It is really, really important, especially in our older patient group as well, just to prevent that frailty, prevent that deterioration that can be so rapid in that cohort of patients. So making sure that bloods are stable, there's no cardiac concerns, and there's nothing else limiting that mobility, getting them up, getting them in the chair, and making sure that you liaise with the MDT to let them know exactly how they've done that to keep them safe on the return. And then we'd always advise to avoid any heavy lifting thereafter the rib fractures, and so for approximately 6 weeks until you've sort of moved into a point of recovery. Nat again talked about the falls management strategies. So yes, really important that once you've done that active treatment with the patient that's there in front of you, liaising with them, the patient's family and the MDT to prevent any further falls, and doing the best we can to make sure they've got the best walking aid that they need that's suitable for the concerns that we've identified, but also that it's safe for them to use at home. Okay, so on to the next part, and we talked really about working alongside the MDT, and it really comes down to that when you're looking at the other medical or pharmacological managements of somebody that's got a rib fracture. So it's very important to think about fluids. We talked about the whole systems approach. Are they having a good input? Are they having a good output? Because your secretions are going to be thicker and much more difficult to clear if you're not hydrated. So it's really important to take that into account when you're looking at the whole patient. Is their fluid chart up to date? If it's not, when was the last time they went to the toilet? Is there any issues with their oral intake? Have they got a dry mouth? Can you see it when you get there? Is there anything that you can do around their oral hygiene and their oral care to make sure that they are then able to taste and enjoy sort of eating and drinking properly? Analgesia we've talked about, that's obviously something that would be prescribed by the doctors, but we can ask for it, and mucolytics just to try and help again with that secretion load. And on there is an antibiotic, but obviously that would be something we would be thinking about as well if there's those infection markers. So I'm now going to move on to the anatomy, and we're just going to talk really briefly about
Lorna.
yes,
Lorna, before we move on, we have a question.
Of course, yeah.
Oh, I've lost where I can't see it, but it's in the question and answers and in the chat. Sorry, it's just disappeared. Oh, here it is. Is PEEP okay with rib fractures? Which device?
Yes, so the PEP we're actually going to move on to in a second. We're going to go through that in a little bit more detail, really. But yes, you can use with rib fractures, and there are some rib fractures that we'd be a bit more cautious about, and again we're going to talk about that in a second. But yes, we will. Have we got a picture of the device on there? Yes, we've got a picture of the device that we use, so bear with us and we will hopefully cover that. But great question. PEP is often something that we are talking a lot about, especially with our sort of junior members of staff and people that haven't managed rib fractures before, because I think it's one of those treatments that you're not necessarily fully aware of when you're at that sort of university learning stage, but it's definitely something that we're implementing here. So yes, we will come on to that very soon. So just briefly quick look at the anatomy. So the upper respiratory tract versus the lower respiratory tract. So thinking back to that active cycle of breathing and how the different upper and lower areas are going to be affected by that, to make sure that we're getting that inspiration, expiration, expansion of the lungs to then clear things through. Okay. All right, and then we're going to move on to the different types of rib fractures. So we've got 3 that are listed here on the slide. And in some ways, this is when we were talking about the PEP element as well. So there are going to be some risks with your rib fractures that you will need to be aware of and keeping an eye out for. So the non-displaced rib fractures, that is going to be a fracture where the pieces of bone remain in line with each other. So they're sort of stable. So they're not displaced. There's no sort of spiky bones poking anywhere that they shouldn't be, and it's all sitting in exactly the place that it should be. The next type is your displaced or complex, which is what it says. So it's that displaced rib fracture. So it means that there is part of the rib that is not sitting in line with the other part, and that's sometimes when we need to be a little bit more careful around what adjunct we look to use, because you are then going to be running some risk of causing further damage to the lung, and which obviously we wouldn't want to be doing. And then the last type is the flail chest, and that occurs when there's multiple adjacent ribs that are broken in multiple places and cause segments of bone to become detached, separate from the ribs. And obviously we're needing to be more cautious with that, again, because there's going to be parts of rib that aren't sort of supported and potentially pose a risk to the structure of the lung. And the last thing that we would want is to be causing any sort of pneumothorax problems, and that's when your adjuncts may well need to be adapted to sort of meet the needs of that patient. Okay, so then I'm going to move on to components of a cough. I'm conscious of time, and I want to make sure that we get onto the bits around the adjunct. So components of a cough, your diaphragm, you need to have accurate function, or good function, efficient function of your diaphragm to be able to create a good cough. And you also need to have a good inspiration phase, compressive phase, and then expiration phase. So it means that if we have a bigger volume in your lungs, you're going to have more force to push the air out. And as you're pushing the air out, it will take the phlegm or secretions with it. So that's why it's really important to have those 3 phases. If you're thinking about your ACBT, what that's going to play into, and making sure that we really get behind those secretions to be able to cough it out. And again, that does play into that pain, weakness. You know, if someone's been on the floor for a long period of time, it may well be that actually their ability to cough is more difficult because they're unable to generate that force to create an effective cough. And then lastly, I'm just going to touch on, before I pass over to Tom, around the oxygen delivery systems that we would also want you to be considering. So is it going to be low flow nasal cannula? And actually, if they're on that, we need to be aware that hydration and things around the airway is important. So whether we can use lubricants around the nostrils to make sure that that doesn't become uncomfortable. Again, ensuring that we're thinking about oral health and oral care so that they're not getting that drying sensation. Or do they need a little bit more? So is it that they need to use a Venturi system or humidified oxygen to make sure that they are getting that oxygen delivered appropriately? And then in the acute phases, when they first come into hospital, following a condition like this, do they actually need a non-rebreathe? Because they need an excessive amount of oxygen to be able to maintain accurate ventilation. But we wouldn't want to keep them on something like a non-rebreathe for too long. So that's all going to be based on monitoring their saturations and then adjusting your oxygen delivery system accordingly. Okay, I'm going to pass over to Tom and we're going to move on to
You're back on mute again, Lorna and Tom.
Thank you. Evening, everyone. So thank you, Lorna and Nat, for the initial parts. That has been very informative. I'm just going to go through really what underpins some of the theories of what Lorna and Nat have said about adjunct application. So we're going to start with active cycle breathing technique, and I'm not going to spend too much time on this one because Nat and Lorna have been through this very well already. And it basically consists of three main components, which is your breathing control, which is your normal tidal breathing. You'll find with respiratory patients and particularly rib fracture patients that this reduced reduced ability to take a deep breath in, this type of breathing technique can be very, very beneficial. And if you're just targeting lung volumes, then I would suggest using your breathing control followed by your standard thoracic expansion. If you think that there may well be a sputum load element to this as well, then adding in that huffing, or what some would class as the FET technique, is a really good thing to add as well. Just think about where you're targeting and how you're targeting when you're doing this as an application. If you wanted to get the more distal airways, then a more prolonged low volume huff will get those secretions moving more centrally, and then following this up with either a mid-volume, harsher, more forceful huff will potentially get that into the upper airways where they can then clear. And don't feel that you have to just do this once, and if it doesn't work, then move on. If you can hear it moving or shifting, or the cough getting wetter, if it's a productive cough or sounding cough, then continue along with it. And like we've said about hydration and etc., nebulization can be a real benefit in moving these secretions, as can fluids and etc. If we can move on, please, to the incentive spirometer slide. At Medway, we use a slightly different incentive spirometer, which is the MediFlow, which some of you may have seen, which has got the orange ball and sets it out from levels 1 to 5. A lot of patients with rib fractures, you'll try and give them the ACBT and it's not as effective, mainly because a lot of patients like to see that visual guide of taking that nice big deep breath in, which both the incentive spirometer that's on this device that's in the picture and the MediFlow orange ball one will obviously give that visual aid. In terms of breaths, yeah, absolutely. On this slide, we've said sort of 5 to 10 breaths. It can be more than that. If you feel your patient would benefit from 10 to 20 breaths, then absolutely. The MediFlow, then the negative of the MediFlow is you haven't really got an idea of what volumes they're shifting in terms of being able to set, whereas this one in the picture has. But yeah, a really good way of encouraging those larger volume breaths where you can try to minimize those risks in those rib fracture patients of having sort of what we class as passive atelectasis and increasing the risk of pneumonias just due to those small tidal breaths that they take. And it's why Lorna and Nat have said that pain is your number one priority with rib fracture patients. Get that under control and everything else will fall into place and you'll reduce your risk of complications. If we move on to PEP, because I know there was a question around PEP and rib fractures. A lot of the evidence now says that PEP is a really good modality to be using when using rib fractures as opposed to incentive spirometers. With the PEPs, again, depends on brand. I know I shouldn't be plugging any brands at all, so I won't, but some of them you are able to able to measure and set your pressure that you want to achieve. We know from evidence-based practice, you want to be guided by a 10 to 20 centimetres of water range to get that beneficial therapeutic effect, using that collateral ventilation to potentially splint airways open and also clear any phlegm that may well be there, or reopen areas of athyletic lung. The idea behind the PEP is also basically equals it goes along with that equal pressure point theory of splinting the airways open so that those secretions can move into the more proximal airways where you're able to clear them. It's a nice device. They're nice devices, and compared to the incentive spirometer, where you have to be in an upright, sort of seated or half supine position, you can use these devices in sideline positions and stuff like that, because they haven't got that ball element, so it's a bit more adaptable to patients' needs. And following on just on the next slide, that still moves on to PEP. With what we've said about ACBT, PEP, and incentive spirometry, we need to have patient engagement and for them to be able to follow instructions to make that treatment essentially effective. So when you're encountering your patients with rib fractures, do also have a think of, is this going to be effective? Because if my patient is unable to follow, if they're confused, if they've got a background of dementia, etc., then, or potentially delirious, then it's not going to be that as effective. You can use these ones are all classed as patient-driven modalities. You can use more of a active assisted pressurized device, like you could move more towards your IPPB, and what we have at our trust is easy PAPs. They're more common in Kent to use in sort of the trust around here, due to a previous therapist that very much promoted and worked with the company. But IPB, etc., as long as you're aware of what your contraindications are and discussions as well. I always say that in terms of contraindications, there are a few that are absolute must not do's, but there's much more emergent evidence to say around discussions with consultants, doctors, medics, and understanding what the risk versus benefit is very much something at the forefront of considering how you adapt your respiratory care. Before I move on to the next slide, just talking about contraindications, just in the chat, can you just think of any contraindications that you might have for, like, your PEP, incentive spirometry, or ACBT? Please. So not so much what you may, I've just seen the one about atelectasis, that's why you would use it. Why might you not use it? Is there anything, does that make it more sense? Why would you not use an incentive spirometer? Okay. Well, okay, lovely. If we move on to, yeah, okay. So we've got a few there. So we'll talk about those on the contraindications. But so what we have come up with is, quite rightly, you guys have said about pneumothoraxes, untreated specifically. What the only caveat I would put to that is, more commonly now, if they've found a pneumothorax and it's under 2 centimeters, they may well feel that it is going to be better conservatively managed and ultimately resolve itself, given a bit of time. What I would say is, if you find these patients, it's about having that discussion with the medics and saying about, are you happy with incentive spirometry and PEP? And getting their, not approval, but their consent or consensus as to understand why you're asking the question. Because if we are giving these devices, we are asking for bigger breaths to be generated. So it may be us asking, do we ask for that follow-up chest x-ray in a couple of days? Or if there is deterioration, then the doctors being aware that this could be the cause. I also saw in there around PEs. PEs is a very difficult one because absolutely, it used to be very much a complete absolute contraindication. Now it's more of a precaution, I would say, when we're reviewing these patients. The literature around the precautions changes all the time. I've certainly found that recently with writing some guidelines that they fluctuate between absolute to precautionary precautions all the time. So just if you're not sure, what I'd say is when you're wanting to give the devices out, they will say on the devices what are their absolute contraindications, etc., and contraindications. And also, as band 5 therapists, use your seniors, etc., as you should. If you're not sure, then just ask. Hemoptysis, I've just seen in the chat. If it's frank hemoptysis, we're not sure where it's coming from, then yeah. But if the doctors know where it's coming from, again, it's that discussion about the risk versus benefit of doing it. What else have we got in there? The inner ear pathology ones, I'd say in terms of PEP, it'd be more your OPEP, where you've got that oscillatory mechanism that you'd be a bit more concerned about tympanic membrane ruptures and sinusitis and stuff like that. If we move on, I'm happy, like if there's more questions, perfect. So what I was going to say here was mobility with any respiratory patient is vitally important. And what I would say is if you can identify that patient is safe to move, whether that be an intubated patient on ITU or your routine rib fracture patient, then get them up and move them. Because this table really highlights, forget a head down position, because that it's a relatively old study where that sometimes was used. That should never be used anymore. But consider stuff like flat, obviously, if you've got your spinal cord injuries that are awaited reviews, further imaging decisions. And then as you'll see the table, the more upright you can get, the more beneficial your lung volumes are going, or your volumes that are able to be generated within your lungs is going to improve. Obviously, most optimal is standing, but you can't keep a patient standing all day. And I'd just encourage that alternation between mobility and if a patient's more comfortable sitting in bed, but in a more upright position, you can offload that abdominal area or contents a lot easier in bed, which sometimes if you've got a larger patient, then that's what will cause that reduction in lung volumes when you sat them out in a chair. Just moving on to my last little bit. So as we've said, sort of mobility, encourage mobility from sitting on the side of the bed to getting onto a commode to the chair and gradually building it up. Little and often is better than trying to do a marathon around the whole ward on your first go, and really get those nursing staff and CSWs on your wards engaged in that mobility and enabling them to do stuff when you are not around. The last slide, I think, just talks a little bit about treatment at latter stages. So we know that this gentleman, Smith, came in with a history of falls and ultimately what causes rib fractures. So thinking about referral to fall services and considering what his limitations are, a lot of treatment does focus quite rightly, well, not rightly, but does focus on the respiratory side of things when it comes to therapy. when looking at rib fractures. I'd always stress to think holistically about your patients when you're giving them exercises. If you're giving them respiratory exercises, make sure they've still got their level of function or trying to achieve their level of function. Rib fractures are very limiting, and if you have drains in for pneumothoraces as well, patients will be very scared about moving upper limbs. And if a patient's been independent at home, self-caring, washing and dressing, cooking all meals, you want them to still be able to reach for that top shelf of a cupboard and get a glass or a plate or a tin of beans out. You don't want them to be limited for a long time after. So think about that scapular setting, as long as you haven't got secondary injuries like scapular fractures, etc. And if you have got those limitations on discharge, rib fractures, this patient's an older patient, but you can have rib fractures from high level traumas, so RTCs, falls from heights, sporting injuries, etc. So if you've got young patients that are builders, labourers, love their sport, make sure that you're thinking about how they're going to return to that level of activity, and whether, if they don't need that package of care or referral to a full service, do they need that onward referral into MSK outpatients to enable them to get that level of function back. I think that is it. And yeah, any questions for any of us?
Yeah, we have a few. So just I'm getting a bit of an echo, so I might just get you to look into the Q&A section. There, the first one we had from Daisy a while ago was in terms of answering this kind of question in an interview, where there is so much potential detail we could go into. How do we know we've provided enough detail?
I would start with, at Medway, when we do ask this question as one of our band 5 questions, and we break it into a 2-part question. So what I would suggest doing is breaking your answer into a 2-part answer. If this was asked as just one big question, I would break that down into thinking about your multi-systems approach to identifying what your problems are, and then thinking as your second part of the answer about what your treatment may be and what your limitations to treatment may be, i.e. pain, communication, ability to follow instruction, or contraindication. Does that answer that question?
That's really sound advice. And Daisy, come back to us in the Q&A if you'd like any further information on that. And then Tuba asked...
Oh, yeah.
You okay?
Yeah.
Tuba asked, people with learning disabilities who have dysphagia and prone to recurrent aspiration pneumonia, can we give ACBTs and chest percussion in their preventative plan?
With a patient with rib fractures, or just in general?
I think it's more in general, but we could answer both.
So with rib fractures, I'd always be very careful around doing manual techniques on the side of the rib fracture. By all means, you can do them on the other side, but I wouldn't be doing it. No patient's going to really thank you for doing them over your rib fractures. But yeah, certainly you can give them, as long as there's a way of them, you being able to write those instructions down in a succinct way for them. Absolutely. I'd certainly say in chest percussion, potentially not as much as a preventative mechanism. Certainly your ACBT with your thoracic expansion exercises and even your huff, etc.
Brilliant. Thanks, Tom. And can the incentive spirometer be used with long-term tracheostomy patients?
I would have thought you potentially can, but I've never done it, and I'd have to have a look and see how you get the correct connector. in order to connect over the tracheostomy. What I'd say is, if you have got that long-term tracheostomy patient, if they've got a tracheostomy where the cuff is down, then don't forget you've also still got that upper respiratory tract connection where you can use that interface. So you, just because they've got a tracheostomy doesn't mean you can't use that airway in order to, you might find that you have to set it at a higher level because you've got resistance within that airway, but there's certainly, you could do it. If you had I know the question hasn't come up, but a laryngectomy patient, you could, within an incentive spirometer, use a pediatric mask and change the interface from a mouthpiece and have that over the laryngectomy, and you would be able to do it.
Okay, thank you. And Lynn has just put in the chat, is the PEP mechanical or continuous from an air supply? And is it breath activated, or like an acapella, it provides PEP only when blown into it?
It's patient driven. So it's when you put on your expiratory phase, that's when you get that PEP element, very much like your aerobicas and stuff like that. So it's not machine driven at all.
Lovely, thank you. And Annie's just popped a question in saying, will the treatment be different if the patient had a history of CF and not COPD?
I know what you're thinking in terms of, do you need that oscillatory mechanism or aspect? I know I'm answering the question, all of the questions, but what I would say is think you can try like OPEPs and stuff like that, and if it was young patients with CF, you can still use your bubble PEP. We still use that in adults, but again, they might not like that oscillatory element. So I'd think more about your mucolytics and hydration and what they might need to go home on. But certainly if you've exhausted all of your mucolytics and hydration and pain, etc., then by all means give OPEP a try. Yeah.
Just it might cause more discomfort with the rib fractures. So as long as you've optimised their analgesia and you're liaising with the patient to keep checking their response to the treatment, then that should be fine to use.
Brilliant, thank you. I think that is it in terms of questions. If anybody else has a burning question, please do put it in the Q&A or the chat. We'll check both. So just to finish off, they have supplied some references for you that will be on the email that you will receive after this event, and we will upload the recording of the webinar onto our South East Coast Regional Network page on the CSP. And just a final plug to remind you all of the CSP graduate support package that is available. Please do click on the QR code and take yourself to link up to that. It's a sign up thing, and then you get access to loads of really useful information. Well worth joining, even if you have got your first post, but if you're particularly struggling with getting that first post, please do kind of join up, and there's lots going on across the UK. We have another session booked in for the new year. So our next session will be on Tuesday, January the 13th from 6 to 7. And the focus for there will be on a neurological case study, be a stroke patient. And we will also be updating with another session around a frail patient as well, coming up in the new year. We would absolutely love if you could go on to Menti and give us a little bit of feedback on tonight. It's very much appreciated. So you can click on the QR code there, or go straight on to Menti and put the code in. And more than anything, I just wanted to hugely thank Lorna, Natalie and Tom for their time tonight after a busy day on the wards. They have come on and done this, a hugely comprehensive session tonight and really helpful. I think for any of you that are current students, this will be amazing for placements. And for those of you trying to get that first job, this will be a great one to listen back to when you get onto those respiratory placements. Thank you all for spending your time with us for the last hour and a bit. And we'll hopefully see you on the next session for the Neuro one. Thank you, everyone. Have a good evening and a happy Christmas if you celebrate, and we'll see you in 2026.